Folks, I'll go ahead and call our meeting to order of the Health Subcommittee of Appropriations. Thank you all for being here. We're going to go ahead and begin, and today we're going to be hearing from the Department of Community Health. We're going to let them make a presentation, and then at the end of their presentation there'll be some time for any questions and answer sessions we want to have. So without further ado, we'll go ahead, and Elizabeth Brady is going to start us off, I think. And Elizabeth, if you would just introduce yourself and the folks that you have with you, and we'll just sort of turn it over to you now. If I can make this mic come on. Is this it right here?
Okay, can you hear me? Okay, I'm Elizabeth Brady, the CFO at DCH. With me is Dr. Linda Wyant, our Chief of Medical Assistance Plans, and Stephanie Papps, the DCH Budget Director. And we're pleased to dive into the Governor's FY17 budget recommendation. Some of these slides at the beginning will look familiar to you. Our agenda includes a brief review of our current budget, and then we'll talk about the cost drivers that are influencing the fiscal year 2017 budget recommendation, and go through all the itemized recommendation items. Okay, on slide 4, this pie chart shows how the state funds are distributed by program within the DCH budget. And as you can see, 97% of all DCH state funds are budgeted in the Medicaid and Peach Care programs, with age blind and disabled Medicaid having the largest share at just over 53%. Okay, moving into the FY 2017 cost drivers, we group these into components dealing with growth, prescription drugs, and different federal directives, and we'll get into each of these when we go through the itemized budget recommendations. Okay, slide 8 shows a 3-year, some actual, some projected, in enrollment for the Medicaid and Peach Care programs, and you can see the considerable amount of volatility we saw in fiscal year 2014 when we transitioned from the 6-month to 12-month eligibility reviews for low-income Medicaid. And we've seen enrollment trends month over month pretty well stabilize, and we're projecting fiscal year 17 to mirror our fiscal year 16 projected. So at the end of FY15, we had 1.975 million Medicaid and Peach Care members. In 16, we're projecting just over 2 million, going to 2.018, and in 17, we're projecting 2.060 million. Okay, moving into the itemized budget recommendations, these reference numbers follow the House tracking document. Item number 1 are funds requested for FY17 benefit growth, and this includes a reduction in the age blind and disabled program and an increase in the low-income Medicaid program. We are still experiencing growth in ABD, but it is less than was previously projected, which is why we have funds available in excess of what we believe we need in that program. The low-income Medicaid side, that projection is based on the enrollment trends as well as medical trends that we have seen going from FY15 to FY16. The two of them together are 102 million, almost 103 million in state general funds. Item number 2 reflects a reduction of $38 million for the federal medical assistance percentage, or FMAP rate. In fiscal year 2017, the state is receiving a more favorable FMAP rate. In other words, the federal government is paying a little bit more of every dollar that is spent. So we're going from a 67.55% federal rate to 67.89% starting in October of 2016. And this item reflects that savings in state funds. Item number 3 is an increase of $26.5 million to provide funding for pharmacy costs attributable to high-cost hepatitis C drugs and cystic fibrosis. The hepatitis C, we have been seeing month over month very high claims costs with those drugs. They've been the highest cost drug for the last 18 months consecutively in the Medicaid program. And cystic fibrosis, we're seeing expenditures as we expected with the new drugs available for treatment of that. So far, these projections are on track to what the actuals are on track to what we've projected. Okay, item number 4 is to reflect savings from the enhanced federal match rate in the Peach Care program, or we call it the EF MAP. Peach Care has always had a more favorable rate than the Medicaid program, being closer to 75% federally funded in Georgia, and now it's going to 100% federally funded. So this reduction of $24.6 million in state funds represents all the state funds that are budgeted in Peach Care now. So the Peach Care budget in FY17 will include only federal funds. Okay, item number 5, this is a continuation item from the amended 16 budget. We are seeing an increase in Medicare Part D clawback payments. Increased rates went into effect in January, and this is largely attributable to the high-cost specialty drugs that we're seeing in areas such as hepatitis C. So it's happening nationally. I believe this year is the highest increase since the program's inception. And while Georgia is a little lower than the national average, it's still very high, in excess of 10%. Item number 6 is to provide funds for the increase in Medicare Part B premiums for members who are duly eligible for Medicare and Medicaid. We're seeing almost a $20 per member per month increase in the Part B premiums this year, and the $21 million in state funds is the projected cost of that increase in fiscal year 17. Okay, item number 7 is $52.6 million for transfer of administration of the Community Care Services Program from the Department of Human Services to the Department of Community Health. The majority of these funds are state general funds, and there is just over $6 million in tobacco funds also included in that number. Item number 8 is to reflect an increase in the hospital provider payments. This revenue is calculated on the hospital's responses to their annual hospital financial survey, and they reported higher net patient revenue in the latest financial survey, and this item reflects that increase in revenue. Altogether, for Medicaid benefits, the governor's budget recommendation is almost $162 million in state funds. Okay, slide 11 is an overview of the operations items that we have in our budget. Item number 9, $1.8 million in the administration program to cover the added expenses of 1095B reporting that is required as part of the Affordable Care Act. The department is required to submit certificates of coverage to anyone who had Medicaid coverage at any time during calendar year 15, and we also have to submit an electronic file to the IRS also this year. And we're working with Hewlett-Packard to perform this function. Item number 10 is to reflect an increase in state funds needed to support the administration budget as a result of a reduction in federal matching funds for certain Medicaid Management Information System, or MMIS-related activities. Upon our request for an extension of our contract with Hewlett-Packard, when CMS reviewed certain requirements, they determined that certain components of the contract were only eligible for a 50-50 match rate, which is standard Medicaid admin, rather than the enhanced match rate of 75-25. This is also, both 9 and 10 are continuation items in this budget as well. Item number 11 is a 3% increase to fund merit-based adjustments of $686,000, and this is spread across multiple programs in the DCH budget. Item number 12 is $11,700, almost $11,800 in state funds for what we call statewide changes, teamwork adjustments, and DOAS and premiums. Item 13 reflects almost $7.7 million in state general fund savings to the state as a result of the 100% federally funded Peach Care program. Peach Care has always had one FMAP rate. In other words, what we get for benefit payments, we've also gotten for administrative costs, and since those are going to 100% on the benefit side, they're going to 100% on the administration side as well. And item 14 is a $3 million general obligation bond request for the Integrated Eligibility System, also known as Georgia Gateway, to complete the design, development, and implementation costs associated with that system, which is scheduled to go live October 1 of this year. In total, the budget recommendation for the operations programs is $2.9 million negative. So altogether, on slide 12, we've included the attached agency items just so you can tie out to the DCH budget. But overall, the governor's budget recommendation includes $159.9 million in state funds. Okay, moving on to the state health benefit plan. Item number 15 reflects an increased cost in Medicare Advantage premiums for the SHBP between plan year 2015 and plan year 2016, and this is the annualization of that effect. The plan did see considerable savings in plan year 2015 when UHC took on the administration of Medicare Advantage, and those premiums have gone up closer to market in plan year 2016, and they're expected to continue to do so. Item number 16 is a $4.2 million increase in other funds, and this caption reflects the organic changes in the SHBP that would be updates to the projection in regards to membership and utilization. In other words, they are not tied to plan design changes or Affordable Care Act requirements. Item 17 reflects a reduction in employee premium contributions for plan year 2016. There was an item in the amended 16 for that as well, a $5.5 million reduction in revenue, and this is the annualization of that reduction in revenue. Item number 18 is a placeholder instructing the department to identify plan design changes for plan year 2017 that will help ensure the financial stability of the SHBP as we move forward. And item number 19 is a reduction in the transitional reinsurance fee. This is also an Affordable Care Act requirement. It was a 3-year fee, and fiscal 17 will be the 3rd year of the fee, and each year we've had it, the fee has gradually gone down. And item number 20 is a recommendation to increase the employer contribution for non-certificated school service employees by $100 per member per month, effective January 1, 2017, taking them from $746.20 per month to $846.20 per month. And finally, on slide 14, this shows an operation level projection for the state health benefit plan going out to fiscal year 18. And by and large, this represents a go forward of the status quo if no other changes are made to plan design, to employee premiums. The only item in here that is not the case is item number 3. This shows the effect of the $100 per member per month non-cert employer contribution increase in January 2017. So this shows that we do have an operational surplus projected going out to fiscal year 17, and then that turning to an operational deficit in 18 if we move forward all things as they are. Okay, and that's the close of the presentation. And we'll take questions.
Okay, thank you. I suspect we may have a question or two. If you have a question, if you'll mash the button on your mic, I can recognize and turn it on here. Anybody? 19, Representative Taylor.
Thank you, Mr. Chairman.
I just had a quick question on page 4, and it's looking at the various different types of services being provided, and it shows administration just 2.2%. And if you look at peach care, that 0.8%, are these just for the medical claims per se, or does peach care, each one of them have their own administration?
I see. Well, the Peach Care budget is only the benefit payments for the Peach Care program. So the administration, in other words, the staff associated to manage the Peach Care program, their expenditures and the contracts are budgeted in our administration budget.
So it's not part of the 2.2. What I'm looking for, what are we paying to have somebody manage Medicaid? What is the administrative fee that we pay to the provider that is managing that? That's what I'm looking for. And I'm pretty sure it's more than 2.2.
Yes, our state funds budget in administration is about $65 million in state funds, and that includes the administration of all DCH programs with the exception of facility regulation and healthcare access and improvement.
Thank you.
So, sure.
Thank you, Mr. Chairman, and thank you for your work in putting together this complicated budget. As you look at the projected number for next year I'm trying to remember the number that you projected last year that was a result of the so-called woodwork effect, where people were enrolling, families were enrolling in healthcare.gov.
Yes.
What percentage was it last year, and what percentages do you anticipate in the future?
Well, the woodwork, we believe that's pretty much been annualized at this point and is folded in. We had projected 55,000 members, I think it was, coming on the rolls as a result of the woodwork, and that projection has been very close to what we've seen actuals. We projected that it would hit sooner than it did, but it did ramp up. So what we have in fiscal year 17 is really a continuation of the enrollment assumptions that we've seen in FY15 actuals and our 16 year-to-date.
Without factoring in the woodwork folks?
Well, right now it's an all-in number, right? But we're not specifically projecting additional woodwork at this point.
So you're just projecting an increase in poverty, or a number of children in poverty?
Yes, and people enrolling. It's about 2.1% that we're projecting in enrollment growth.
I have a couple others, but if anybody else. I wanted to ask a little bit about rates for providers. Last year we did agree to increase some rates for certain providers. I've heard a lot from some of the other therapists, OT and PT therapists, about their rates. And do you have estimated costs of what it would cost to increase those? I mean, they're really critical to the development of treatment for children, particularly with developmental issues.
Right. Right now we're working on an analysis for, I believe it's House Bill 700, that addresses therapy services in the CIS program. So that is under development now.
And the last question, if I may, Mr. Chairman, has to do with new CMS guidelines with regard to including the treatment of people on the autism spectrum. Mm-hmm. And do you intend to comply with that new federal regulation? And if so, why not?
Well, we are aware of the guidance that was issued by CMS and have had conversations with them and are working on, options that we may be able to utilize to address it. Linda, do you?
I don't at this time have a time frame for when those might be implemented.
I think we talked a little bit earlier about the efforts we made to deal with the increase in the diagnosis of children on the autism spectrum. We included a pretty large sum for the state health benefit plan, And has that utilization proved to be an appropriate projection? And do you have a projection, should you find a way to cover the children on the spectrum in the rest of the Medicaid program?
Sorry. The utilization on the state health benefit plan side has been lower than what was projected. I can get you those numbers, but I know they are lower. We haven't had as many children utilize the services yet as we had projected. And on the Medicaid side, we're putting together options. The projection would vary based on the delivery, which categories of service it's opened up to, and what like PA requirements we would have.
And so you have, I mean, there are a developing number of people who provide treatment for children on the autism spectrum, and there are not very many of them. I suspect that's why the pickup was so low to begin with. But the OT and PT fees are certainly a piece of that puzzle. But I'd be very interested in your continuing work on your interpretation of the guidance from CMS and kind of the numbers you come up with. And also the reasons that you can figure out that the pickup of the state health benefit coverage on autism has been so minimal.
Okay.
I mean, is it true that it was somewhere under 200,000 and the projection was 2 million?
I'd have to go back.
Well, if you can help
sure.
me with that information, I'd appreciate it. Thank you.
I'll do.
Representative Hughley has a question.
Thank you, Mr. Chairman. Thank you for the presentation. I know we've mentioned this before, but I want to ask you about the increase in the employer contribution for non-certificated school service employees. My concern is that many of these employees, some of these employees don't make $846 a month, and that's what the insurance cost is going to be to their employer. And in the past, we've heard that they have a higher usage rate, but is there anything being done to encourage more healthy lifestyles among this group of users?
Well, we do. The state health benefit plan does contract with Healthways to administer the wellness benefit for the state health benefit plan, which is open to all members. I'm not aware of school service personnel being specifically targeted for different outreach efforts, but everyone is available to participate in the plan, the wellness activities, and earn the incentive dollars. The issue in the past has been the funding gap between the expenditures of the non-certificated school service personnel and what the employers have contributed to fund those expenditures. So this increase is taking a step toward narrowing that gap further.
So you anticipate that that's going to continue to be the case, that the gap is going to continue to rise, or are you just trying to catch up with where you are now, or what is the situation?
This will narrow it. I mean, we do project that expenditures will continue to go up, for every group to some degree. And we do have, we're seeing active employee enrollment go down a little bit, and the employer contribution is only assessed on active employees. So if we assume that revenue doesn't change, if we keep this 746.20 in place, and healthcare costs continue to go up, that gap between what is expended versus what is funded would continue to go up as well. So this $100 PMPM increase isn't projected to make the gap go away. It's just projected to narrow it.
Thank you.
Okay, Representative Hawkins has a question.
Thank you, Mr. Chairman. Sort of a conundrum that we run into sometimes with health providers. Like I've heard from the OTs and PTs how they're now, there are the claims manual manipulation, which is working the joints, which I've had done in the last 2 years. I've had a knee and a shoulder, so I've had a lot of manipulation done, which really helps the healing. But I was just told the other day that that's not being covered now by the insurance companies. I don't know if that's going to be involved with LIM and EBD, understanding that only CMOs deal with LIM. But that's just an example. I guess where I'm going to with this is DCH develops contracts or signing contracts, negotiates contracts, and then when we find a problem in coverage or payment for providers, we're left going to the insurance commissioner who tells us, rightfully so, that he can't do anything because they are escaped from the enlistment. So I guess my point is to you, as you develop these contracts with the CMOs or the insurance companies for state health benefit, is there any way we can have a little more input into that, either by written message or statements to DCH?
Okay, we'll take that back to leadership, sir.
Yeah, because we're hearing from the people that we represent. That's the reason we come down to Atlanta. If we can't represent the people who elect us, we don't need to be down here anymore. I appreciate you helping me with that.
Okay.
Let me ask a question. It was raised a little earlier on this codes where we had bumped up the reimbursement rate on certain codes. It's my understanding that on those primary care codes that the CMOs are paying that enhanced rate now. Is that correct?
Yes.
But on the other population, that we're still waiting on a approval of our state plan from the feds to be able, you can't pay that without their approval. Is that right? You have to have the plan approval. And we're into what now, about the 7th month of that or so. Do you have any idea when you reasonably could expect either, yes, we're going to approve the plan, or no, we're not going to approve it?
No, sir, I don't.
You don't have a crystal ball, do you?
I wish
Yeah.
I did. Although we have resubmitted answers to questions to CMS as of the 20th of January, and we've had ongoing conversations with them. And I've mentioned it to a couple of people at CMS in the last week and asked them if there was anything we could do to escalate it.
Well, please, let's stay in touch with them. And it sort of brings me around to this, too. I'm hearing from some folks out there that finding a dentist who participates in the Medicaid program now is becoming more and more difficult simply because of the reimbursement rates that Medicaid pays. And if you remember, I don't know, it's been 15 years ago or something like that, we got to the point where you could hardly find any dentists in the state that were participating. And it wasn't that they didn't want to do it, it's just that they couldn't participate and receive a payment that was less than it cost them to perform the procedure. So I'm concerned if we don't pay our providers, whether it's the dentist or the hospitals or the doctors or the pharmacists or the OTs or the PTs or whatever it is, a reasonable rate for what they do, they're not going to be able to do it. And we can look on a map, and the CMOs and the others will put a pin in the map and say we have geo coverage, but the truth of the matter is there may be a dentist there for 10,000 people in that particular area, and yes, they have coverage, but trying to really get an appointment to get in to see them is difficult. So I hope we'll keep that in mind as we look at this, and I think the idea, if they'll go ahead and approve these codes for us where we can pay that enhanced rate, it'll help the providers and some of our rural hospitals and others as well. Representative Quick has a question for you.
Thank you, Mr. Chairman, and thank you for your presentation. My question is about item 8 on your presentation with regard to the hospital provider payments number. And I just want to make sure I understand how all these numbers fit together. When I look in the budget book estimate, it was about 11.7 million, which was the estimate for the FY 2017 recommendations, but I see 13,564,771 here in your presentation, and then I'm assuming that's allocated out in some way that I'll ask you maybe a little more about. But can you explain the discrepancy there? Is that just a projection, or am I misreading the hospital provider payment increase or change, proposed change on from the budget book?
Speak into that mic.
Okay. It is referenced 3 times in the budget recommendation, once in ABD and twice in LIM. I can get back to you on what the second limb adjustment is.
And so then the follow-up then is, how do you determine internally from the Indigent Care Trust Fund how to allocate those payments to these categories?
Between ABD and limb?
Yes, ma'am.
Well, actually, the initial allocation of the hospital provider fee came about when the managed care quality assessment fee went away. Do you remember that fee? We called it the QA fee, or the quality assessment fee. That's a fee that used to be in place that would fund the Medicaid budget. And it was several years ago that there was a federal requirement that you had to assess the fee uniformly along all managed care companies or not do it at all. And that QA fee represented a considerable hit to the Medicaid budget. So when the hospital provider payment program was initially implemented, the majority of it was budgeted in the low-income Medicaid program because that's where the quality assessment fee was that supported the low-income Medicaid expenses. So the allocation of the fee isn't necessarily specific to anything other than the needs of the budget at the time when the hospital provider fee was implemented.
So in terms of carrying it forward then to fiscal year 17, how do you now make a determination as to what you put into those two categories, or in this case 3 categories?
It's allocated based on the base distribution of the fee. So for instance, the majority of the fee is budgeted in low-income Medicaid. So if we have an increase of $13 million overall, we'll allocate it between low-income Medicaid and ABD according to the base allocation. That's the way it's traditionally done.
And if I could, Mr. Chairman, just to follow up, could you maybe help me understand how the hospital care for indigent program, which is outlined in 31-8-1, is administered by the department, and how you integrate that into the Indigent Care Trust Fund payments?
I can't at this time, but I can get the information to you.
Okay.
Thank you, Mr. Chairman. I did have another additional question, and it has to do with page 10, number 3, the prescription drug costs. And I know how miraculous this hepatitis C medication is, and you actually are having cures once you take this medication. I'd like to know how many patients we have in a year, and are we getting new patients? Because it used to be that you would stay on this medication forever and ever. Now you're taking it, it's much higher, and then you're off the plan. So are we refilling, getting new people with the same disease over and over? So I've kind of wanted to get a number, if you have that.
We haven't requested updated numbers on hepatitis C in probably about a year, but I ordered those last week, so I should have them in the next week. But the last time we looked, we had about 5,000 patients that had a diagnosis of hep C within the fee-for-service population, and it was about 800, I think, on the CMOs, so considerably smaller population. But as the screening guidelines were put in by the CDC, we have seen those numbers go up as people have been routinely tested for hepatitis C. And remember, this is just a diagnosis. If you haven't been screened according to the CDC guidelines, or you didn't have some reason to be tested for it, we may not know about you. And what you are seeing in the numbers of patients, we've treated over 1,000 patients for hepatitis C on the fee-for-service program so far.
I would kind of like to see how it's broken down. How many are using this new medication? Not only is it better for them, we need to steer them there and have them cured.
Absolutely. Our utilization is almost exclusively in the Harvoni product, which is the Gilead product. Sovaldi is used very little. It does have a little bit longer course of treatment. It is not an interferon-free treatment like the Harvoni is. Most of our fee-for-service patients are in Harvoni.
Thank you. It's a great product, and it's doing miraculous things. I would think one day we're not going to have them all. I know we always get new patients, but I figured we'd have a bunch all at once it's approved and it's a new medication, but I thought it might plateau. So.
I think it will. I think we still have a large untreated population, though.
Okay.
think we've only probably treated 20 or 25% of our population. I think part of that might be limitations in capacity in the system. I don't really know. We did see warehousing for a long time before these new drugs came out. And as you know, we've just had a new approval of a Merck product, had another
Right.
product a few months ago. So we're starting to see some additional agents come in, which is a good thing.
It is. It is. Thank you very much.
Thank you. My question touches on what Representative Taylor was just speaking about, and I had been curious about this, and I'm glad that I'm having an opportunity to talk to you about it. Item number 3 and item number 5, with the increases in this in the Hep C drug, is there a mechanism or a way for the department to track how much of this is repeat patients, because I remember last year when we were talking about this, and I think the year before when it was implemented, a massive problem is people, they get cured on it, and then they're right back in the door, within a year. Mm-hmm. And I just didn't know if that, if we know how big of a problem that is, and if there's even a way to track it.
We can look. I haven't looked at that number in probably 12 to 18 months. We did look once. It was not a very large number that got retreated,
Really?
and they were actually treated on some of the older agents that were much less well tolerated. We might have enough experience now that we can look and see what some of the more recent agents, what the retreatment rates look like. We can certainly look at that for you and get back to you.
We'll follow up, Chairman. And just to refresh my memory, about how much is it for a cycle to treat a patient?
Probably $60,000 to $80,000 for a course of 8 to 12 weeks of therapy. That's on the retail side. Obviously, there are rebates that we get back on the back side that probably reduce the total expenditures by 30 to 40%.
Okay, I remember it was expensive. I just
It is quite expensive.
I always get confused about which of the waivers is in your program. So you manage the independent care waiver, and I've heard from a lot of people who use those providers to help them stay active and willing to have jobs and carry on in the community. But there's not been a raise for those people who provide those services in a pretty long time. Have you done any analysis on what it would cost to increase the independent care waiver workers' fees that you pay?
I was thinking we had, but I'll have to go back and look.
But I'd be very interested because it's a key to keeping people with these serious disabilities working in our communities to have somebody to care for them in a unique way.
We do have one. We do have a recent one. Okay.
Great, thank you. I would very much appreciate that.
Okay.
I'd like to ask you a question. You mentioned in your presentation that the FMAP on the Peach Care had gone to 100%. And do you anticipate that will stay at 100%? Because it's figured just like our regular FMAP, I guess, is it every year that it's figured? Or do you anticipate that'll stay at 100 for any period of time or what?
Indefinitely, I don't know when or if it will change.
I know I don't know the formula, but I know there's several things involved in how that's handled, but that was certainly a help with the 100% of that, yeah.
Right. It does.
Okay. Do we have other questions from the committee?
Can I go back
sure.
to your question, Representative Quick? I think I just figured out what the third adjustment is in the hospital provider fee. It's $1.8 million of the hospital fee was budgeted in the Peach Care program, and since all those funds are going away, I think that $1.8 million is going to be budgeted in LIM. So that's why, like, the reduction to the Peach Care budget is just over $24 million, but $1.8 million of that is the hospital provider revenue. So since Peach Care is going out completely, it's moving to LIM.
But is there a formula Is there a formula as you're applying those funds, or is...
It's just the allocation from the first year that the hospital provider fees were in the budget. So,
It's continued?
yes.
And has anybody examined whether or not that still matches up as far as those payments are concerned in terms of those categories?
Not that I'm aware of.
Representative Gardner has another question for you.
So on page 10, there are a number of requested items that appear to me to be items that are needed for adults in our community. And the number of state dollars that we are spending, are these, I'm looking at the pharmacy costs and some other issues. I mean, are these state dollars that were we to provide access for more adults in our Medicaid program would be paid for by the federal government instead of state dollars?
I think it would be the match it is now. It would be increased costs for the federal government and state government.
So that they wouldn't be paid at a 100% like they are in some other states for the reimbursement for Medicaid adults, because we've not chosen to implement that part of the program. Sorry, I was trying to be subtle for a change.
Close. ABD.
But, I mean, as we look at this budget and the need for funding for providers in hospitals, we just have to find a way to work with the federal government so that adults in Georgia have access to what other states do. I mean, my constituents who are taxpayers are really tired of paying taxes for people who live in Alabama and Louisiana and Michigan, because they've chosen something that we have not. So I don't want to beat the dead drum, but it's important to think about when we look at how we struggle to make this budget work, the funds that might be available in our state should be available, in my opinion. Thank you.
Thank you. Any other questions or comments? If not, thank you all very much for coming. We appreciate this. We'll be having another meeting, just to remind you, tomorrow, and we'll have public health and the Physician Workforce Board will be here. And then on Wednesday, we'll have a public comment session. We'll begin at 2 o'clock, and there'll be a sign-up sheet for anybody that would like to come and be heard. We'd ask that you come and sign the sheet so that we would try to be able to accommodate everybody in a timely fashion. So with that, we'll adjourn the meeting. Thank you all very much.
Thank you.